Right, I think we'll start. Hello, everybody. Welcome. My name's Sue Walker. I'm one of the co-leads from the People Network project. For those of you that don't know about People, it's a UKRI-funded transdisciplinary network that brings together GPs, vets, dentists, designers, pharmacists, and behavioural scientists, and we're interested in the development of interventions to promote informed and prudent academic use in the community. So that's People. A little bit of housekeeping before I introduce our speaker. We're going to be recording the session, so switch your camera off if you don't want to be seen. It would be really good if you could use the chat function to introduce yourselves so that everybody knows who's in the room. And we will have a discussion and questions afterwards using the raised hand and chat function, which Chica and I will try to keep control of. Everybody gets a chance to speak. But without further ado, I'd like to welcome Dr. Melanie Huster as a speaker today. Melanie is a postdoc researcher at the University of Antwerp, working with the ELISA research group. She's continuing her qualitative research in the field of implementation science with a focus on infectious disease and pandemic preparedness. In her doctoral work, she was focused on the implementation of rapid diagnostics for acute respiratory tract infections in European primary care settings. And today she's going to share her experience of qualitative research, soliciting the views of clinicians and patients in the implementation of point of care tests within the context of antimicrobial stewardship. I'm really looking forward to what you've got to say, Melanie, as I'm sure everybody here else is. So now, welcome. Thank you very much for joining us today.
Hello, thank you. Thank you again for the warm introductions and also for inviting me to speak today. I will share my screen if that's okay, just so that I could share some of my slides. Let me have a look. Okay. Okay. I'm assuming that everyone can see my slides then. I see some people nodding, so that's already good. So as Sue says, my PhD was really around implementing rapid tests. And as part of my PhD, what I did was I looked at the different levels of a health system to sort of build a picture of the areas of complexity using an implementation framework and to understand where we should be putting our efforts in to reduce some of those complexities that we see when it comes to implementing these tests. So for today's webinar, I'll be presenting one of the studies that we conducted during my doctorate. When I was invited to present at this webinar, I knew that I wanted to focus on the complexity side of things, but it wasn't until I actually began preparing my slides that I realized that my main goal was to convey how we can make sense of the complexity. So I ended up changing my title just slightly last minute, and it's now going to be about unpacking that complexity in implementing these kinds of rapid tests. A brief overview of the topics that I'll be discussing today. Just a bit of background information. What do we mean by implementation, first of all? Implementation is the process of putting an innovation into practice, integrating it within a very particular setting, organization, or system. In the past, researchers sort of assumed that if there was enough evidence supporting an innovation, then clinicians or patients or the healthcare system would naturally adopt it. The flowchart that you see shows a very step-by-step model of how implementation should happen in an ideal setting, and it's very appealing. We like the sort of clear, linear processes that make complex things look very simple and manageable. But in reality, implementation doesn't exactly unfold in this neat way. It's rarely a straightforward path, and this kind of model overlooks some of the influences at an individual level, at a social level, cultural, economic, political factors, all of which actually deeply shape how innovations are actually adopted. And we see this in practice. The failure rate for actually implementing complex innovations can be remarkably high, anywhere between 30% to 90%. So what does this mean when it comes to point-of-care tests? Well, we know that in EU countries such as Belgium, Greece, Germany, Croatia, just to name a few, are not routinely using point-of-care tests such as C-reactive protein or strep A tests in primary care settings. And this is despite the fact that the European Union really wants member states to implement them more systematically. We already have the evidence there that point-of-care tests can help optimize antibiotic prescribing to a degree. And we also know that they have the potential to sort of reduce healthcare costs. But despite this evidence that we have, their implementation remains inconsistent and still quite limited. So this shows us something quite important. It shows us that having evidence is not enough. Evidence alone does not guarantee that an intervention will be implemented or embedded into routine practice. So point-of-care tests are not just machines that you can just place in a consultation room and expect prescribing behavior to change. They exist within this broader, complex system that is influenced by clinical habits, professional norms, patient expectations, and the broader organization of healthcare. So if we want to understand, or if we really want clinicians to sort of engage with these tests, we need to go beyond numbers and we need to go beyond those outcomes. We need to understand how clinicians make sense of these tests in their everyday work. And that's where qualitative research can provide really powerful and in-depth insights. The study that I'll be presenting today will help unpack some of that complexity when implementing point-of-care tests. The study was a systematic review and a metasynthesis that we conducted. Just a brief overview of what a metasynthesis is. A metasynthesis is a method of combining and interpreting the findings from multiple qualitative studies to create a new and deeper interpretation by analyzing and reinterpreting some of the themes and concepts that have been developed. This is very useful for us because it allows us to really understand exactly what is already known and where the gaps are in research and where we should be putting our efforts in. So in this case, there are already loads of qualitative studies on point-of-care tests in primary care settings, and they provide very rich stories on clinicians' and patients' views on the use of these tests in these settings. These studies also explore some of the concerns that some of the patients and clinicians might have, and they also propose strategies to address some of these concerns and these barriers. So our goal was to map out these different influences and factors that impact test use and the interventions that may actually support their implementation in primary care settings. So what we did was we carried out a standard systematic review process, and our inclusion criteria was qualitative methods or mixed method studies with a qualitative component, clinicians or that focused on clinicians and or patients' views or their experiences on the adoption or the use of the tests for managing acute respiratory tract infections in primary care settings. And we identified a total of 33 papers. We carried out a quality appraisal with the critical appraisal skills program checklist on all 33 papers with 2 reviewers, and none of the papers were excluded. The type of analysis that we conducted was a thematic synthesis. So what this means is that each study is coded line by line and organized into higher level categories. We then used mind mapping techniques to organize the categories visually. And after many rounds of review, we agreed on a diagram that best fits the results that we found. We also carried out an additional layer of analysis. So from the categories, we identified influences and contextual factors. And we also identified interventions from the studies to sort of help build up our diagram further as well. Before I go into more detail on the qualitative components, I just want to give a breakdown of the characteristics of the studies that were included. So most of the studies actually took place in Europe, with the majority taking place in the UK, actually. This was followed by studies in North America. They mainly took place in general practices, followed by pharmacies. On the other hand, some of the studies didn't exactly specify what they meant by primary care setting, so that's falls under the unspecified primary care setting group. More than half of the participants that were involved in the studies were GPs. This was followed by nurses or healthcare assistants, and patients made up 14% of the studies involved, followed by pharmacists. In some of the studies, they also included other stakeholders involved in primary care settings. More than half of the point of care tests that were investigated were C-reactive protein tests, with 19% of the tests being for strep A tests. Some of the studies didn't exactly specify what type of point of care test that they were investigating, but they just generally use that term point of care test or rapid test for acute respiratory tract infection. And a small percentage of the studies actually used tests that were multiviral or were a bacteria versus virus test. So the first part of our analysis involved identifying those factors that impact point of care test use from the studies. We identified a total of 38 factors, 28 from the perspectives of clinicians and 10 from the perspectives of patients. I'm not going to go into listing all of the factors for each, but just to paint a picture of some of the factors from each of the participants. So from the clinicians, this included concerns around inaccuracy of the tests, wanting further evidence on the clinical utility of the tests, concerns around the impact that it would have on the length of the consultations, and the fact that point of care tests may reduce clinical uncertainty in the end. From the patient's perspectives, the factors included concerns about how invasive the tests were going to be, the costs of implementing the tests and what that would mean for the patients, and this lack of understanding of why clinicians would use point of care tests at all. We also identified interventions from the studies that could help support some of the factors that impact point of care test use and implementation, or to address some of those challenges. So we defined an intervention as a single method or strategy for promoting change. These are the interventions. So what we have here are 14 interventions that were identified. They've been all listed in front of you. And these are the interventions that have been proposed by the authors. So what we then did was we made connections between the interventions and the factors based on what was being said in the studies. And this helped us build our diagram. So this flowchart here, this diagram, is an overall picture of what we found. We found that factors that we identified impacted the use of the test at different levels. So some of these factors existed outside of a consultation, and they really revolved around encouraging the adoption of the test in primary care. We then move towards what happens within consultations. So this captures how clinicians and the patients make sense of the tests in their consultations, and further, what was the impact of the test on the delivery of care. And finally, we move into the post-consultation phase. So this is around the tests and the impact that they might have on future health-seeking behavior. What I will do is I'll be going through each of these points in a little bit more detail and discuss some of the factors and the interventions that can target, that have been highlighted within each of these different components. So the first part is around what happens outside of consultation, so encouraging adoption. What you're going to see are a combination of blue boxes and brown boxes. So the blue boxes are really focused on clinicians, and the brown boxes were from the patients. We grouped them together depending on how they resonated with each other as well. So if we start at the beginning, clinicians needed to really be convinced of the value of the tests. Many actually expressed doubts about how accurate and effective these tests really are, and whether they truly make a difference when it comes to antibiotic prescribing, because they felt quite confident in their clinical judgment. They also raised concerns about the costs of implementation and the lack of training on how to use the tests properly. From the patient's perspective, there were worries as well. These were around how invasive the tests might be, how much they would cost for them, and even skepticism around why GPs would want to use them in the first place. In our review, we identified 6 different types of interventions designed to address some of these concerns. These focused on clinicians. So these focus mainly on the clinicians, with interventions like reimbursement, guidelines, and training to really help clinicians see that value when it comes to using point-of-care tests, and to provide them with information from credible sources on how they can help as well in their practices. Both clinicians and patients also shared worries about workflow disruptions. So this meant longer consultations, extra steps, or having to leave the room to access a test. The evidence really suggests that training clinicians reduces these concerns once they become familiar with that process. And it makes it feel less disruptive at the end. Also, making the point-of-care test more portable also helps them integrate the tests more smoothly into their everyday practice. Pharmacies were also seen as a potential space for testing. They could relieve the pressure on GP practices, and improve access for patients as well. However, there were still some challenges that actually existed. So pharmacists reported limited access to medical records, and sometimes strained relationships with their GP or with GPs was a barrier to the use of the tests. Patients, on the other hand, they saw clear benefits. Pharmacies were nearby, open outside of GP hours, easy to access, but there were still those barriers that existed for them as well. Many patients didn't know that testing was even available in pharmacies, or were referred to pharmacies by their GPs that didn't actually offer them. So to address this, the clinician-focused interventions really focused around granting pharmacists, for instance, with prescribing authority, improving communication between GPs and pharmacists, whilst the patient focused interventions emphasize better communication and awareness campaigns, so advertising and marketing to ensure that people know where and how they can actually access testing. We then move towards within consultations. So what happens inside the consultation room where point-of-care tests actually come into play? So clinicians identified several scenarios where the test can add real value, and this included, but not limited to, of course, helping reduce diagnostic uncertainty, guiding antibiotic prescribing, making that distinction between bacterial and viral infections, assessing infection and severity, for instance, and supporting decisions when patient records weren't available, for instance, in out-of-hour services. From the patient side, many believed that the test actually helped the clinicians make better, more evidence-based decisions. So it gave them the confidence that they were receiving the right treatment at the end. The interventions reported in the studies included having clear guidelines that really specified where the tests should be used, or when the test should be used, sorry, and helping clinicians integrate them more consistently into practice. Another was having tests that could detect multiple strains of bacteria, for instance, as being quite useful. Point-of-care tests were most often used to also inform antibiotic prescribing. So GPs emphasize the importance, for instance, of balancing the test results with their clinical judgment and avoiding this over-reliance on the test alone. Pharmacists, meanwhile, found that the tests were quite instrumental in their decision-making process. So, for instance, elevated CRP values were seen as a reason for them to refer their patients to the GP, whilst low values meant self-management recommendations. However, some of the patients actually misunderstood what these tests really measured. So, for instance, for the C-reactive protein test, they believed that the test detected bacteria in the blood. So, in the end, the interventions that were identified were focused towards the clinicians. They included training on how to integrate the test results better with clinical assessments, how to find a balance between the two, and guidelines really clarifying when tests should be used in certain situations as well. We also found that clinicians had varying levels of confidence in interpreting the test results. So for CRP, for instance, there was an inconsistency across studies in what was counted as a high value and a low value. So the cutoff values actually ranged from anywhere between 50 to over 100 milligrams per liter. Pharmacists, on the other hand, had high confidence in referring patients with higher than expected CRP values to GPs, but what higher than expected CRP values was not exactly evident, was not exactly clear in the studies. And when it came to strep A test, GPs and pharmacists felt very confident in interpreting the results. Patients generally trusted their clinicians in interpreting the tests, but they still expressed concerns about the precision of the tests, which then could influence the reading of the tests as well. To address some of the concerns that we see across these two categories, the interventions were mainly aimed, again, towards the clinicians. So guidelines with very clear cutoff values showing when antibiotics are truly beneficial, and providing training to clinicians when it comes to interpreting results confidently and how to manage those unexpected outcomes. Moving into what happens during those patient-clinician conversations after the point-of-care test had been used. So some clinicians found the test incredibly useful when explaining non-prescribing decisions to patients. The test results really gave them something concrete to show patients, helping to reduce pressure to prescribe antibiotics and really making it easier for them to say to their patients, well, you don't really need them. They also saw the tests as valuable educational tools, helping patients understand that antibiotics were not always necessary for conditions like respiratory infections. There was one study that showed that GPs emphasized that the certainty of the test to patients, even though they had reservations about the test themselves as well. So there were also some clinicians who were worried that the point-of-care tests might actually disrupt this communication between the patient and between themselves and the patient. From the patient perspective, many appreciated that the test really helped to avoid unnecessary antibiotics. They found it very reassuring, and felt more confident about managing future infections. But not everyone really understood why antibiotics were not prescribed even after being tested. So this highlighted a communication gap. The interventions that were discussed in the studies were again aimed towards the clinicians, so training and communication skills to help explain the test results clearly and manage those expectations from the patients, and providing patient information materials such as leaflets or visuals to support these discussions with clear and trustworthy information. Overall, the clinicians found, both the clinicians and the patients valued the tests in their consultations. They found that the tests reassured the patients and strengthened that patient-clinician relationship. Sorry. Clinicians felt that the patients appreciated having this sort of objective test result rather than just relying on clinical judgment. And pharmacists felt that their testing services improved their professional image and attracted new customers. However, there were also some clinicians who felt that improving communication skills and using patient-facing materials was actually more beneficial for their patients because they found that communication is a key component in their profession. From the patient's perspective, the studies reported that they really felt reassured by their consultation, regardless of whether antibiotics were prescribed. This was for most of the patients. However, there were still some that felt dissatisfied that no antibiotics were prescribed, or they even felt that the tests made their care feel a little bit more impersonal. So interventions aimed towards the patients, for instance, with the use of communication materials can perhaps alleviate some of those concerns in reassuring patients and helping them feel engaged more within their consultations. Moving into post-consultation phase. So this part describes clinician and patient views on how tests can impact patients' future health-seeking behavior. So clinicians were primarily concerned that patients will demand testing, so encouraging patients to reconsult in the future, resulting in this medicalization of self-limiting infections. But not all of them actually shared this view. From the patient side, there were mixed opinions. Some said it would not affect their consultation behavior, whilst others really said that they would consult earlier to go get tested. Studies showed that training clinicians, therefore, in communication skills and the use of communication materials can actually help patients understand self-limiting infections and when antibiotics would be necessary. So in this effort, therefore, to sort of prevent the medicalization of self-limiting infections. This is an overall diagram of what I have just described to you, but just an overall chart. We also found from our analysis, however, that there were some factors that were not linked to any intervention or linked to any interventions in the papers. We therefore made suggestions on where the identified interventions can address factors that were not described in the studies. To address other factors that were, not described in the studies. And there were a number of them, but just to give an idea of what this looks like, one concern was that incentivizing the use of the tests could lead to their overuse. So, for instance, having appropriate reimbursement and incentivization schemes can mitigate some of this. The incentivization scheme could be non-financial, for instance, or reimbursing clinicians when the tests were used in appropriate cases as listed in the guidelines. Where patients were concerned with the use of point-of-care tests in consultations, clinicians trained in communication skills and with a combination of patient-facing materials, patients may be more open to accepting these tests if they understood why and how the results can help them and their clinician, which leads to another factor, which is around the lack of understanding of why clinicians use point-of-care tests. Again, these interventions can help address these concerns and reassure patients at the same time. This is just an overall diagram to show our suggestions between the factors that exist in the categories and linking them up with our own suggestions of interventions the interventions that could help address some of those factors as well. If you're interested in wanting to know where our suggested interventions can be placed, you're welcome to read our paper in full. and this is the reference for it. So what do our results tell us, and what do we need to consider when it comes to implementing point-of-care tests in primary care? A qualitative study that was conducted by Borek et al. Had showed that clinicians' antibiotic prescribing decisions are influenced at both system and at a practice level, which really shows that importance of adopting this whole systems approach when addressing antibiotic prescribing. We argue that a similar approach may be necessary in point-of-care test implementation. Our results show that there are challenges that exist beyond the control of clinicians and patients, and that it may be important to involve other stakeholders as well and engage with the wider health system when implementing these tests. They also show that just placing the tests in the practices is not enough in the process, and to ensure that they are used appropriately as well. The other thing that our results tells us is this ambivalent nature, perspectives of clinicians and patients on the use of these tests. Although there is that potential role in clinical practice, there are also challenges. So the uncertainty behind that added value, the inappropriate use of the tests, the impact on workflows, results not aligning with clinical assessments, for instance. And from the patient's side, it was around concerns around the costs on them, the accuracy, and not receiving antibiotics. These drawbacks, therefore, really need to be addressed if these tests are to be widely implemented. Different primary care settings had different perceptions on the tests. I didn't go into too much detail on the differences between the general practices and pharmacies, but our results do show that implementing the tests in pharmacies may affect how these tests are actually perceived. So during the pandemic, we've seen an expansion in the role of pharmacies to provide services like testing and vaccinations. So there is a potential role there for them in the future in managing infectious diseases. Our study showed, however, that there was a difference in the weight of the point-of-care test results in decision-making. So for clinicians in general practices and in out of hours, they really discussed finding this balance between clinical assessments and the results from the tests. And in some cases, they even prioritize clinical assessments over their results. In pharmacists, however, they discuss results as being quite instrumental in their decision-making process. So if tests are to be implemented in pharmacies, interventions other than the ones that we've identified in our study may be needed, such as training pharmacists to carry out clinical assessments, for instance, or guidelines may need to be tailored to sort of provide a protocol for pharmacists to follow. There's also a chance that implementing these tests in pharmacies can lead to the medicalization of self-limiting infections, especially in contexts where consulting with a GP can be quite costly for the patient. So we saw in a study in the US, for instance, where patients went to a pharmacy and they argued that in the future they would go back to the pharmacy just so that they could get testing done earlier. So to avoid this, pharmacists can actually benefit from interventions like training and communication skills as well to help manage patient expectations for the future. We identified 14 different interventions that can address the many factors that actually influence how point-of-care tests are implemented across the different levels of a healthcare system. This really shows just how complex the process is and how much support both clinicians and patients actually need for these tests to be used effectively and appropriately. There wasn't a single magic bullet that could make implementation work. Instead, what we found was that a package of interventions may be needed, each one tackling a different piece of the puzzle or a different piece of the phase at different stages. What's still unclear, though, is how these interventions can interact with one another, or which combination of the interventions truly make a difference in practice. What's more is that one package of intervention might work in one setting or one country, but might not work in others as well, which means really matching the package of interventions to meet the needs of the context. At the beginning of the talk, I mentioned how we like to bring order to complexity by creating these linear diagrams and drawing connections between factors and interventions. And that was our way of making sense of it all through all of the qualitative studies to date. But the reality is that there are many, many players that are involved in this process, stakeholders and organizations that really shape how the tests are being rolled out. So think about those designing reimbursement schemes, writing clinical guidelines, for instance, building training programs, or creating engaging patient materials. Each of them also play a very crucial role in developing what they need to do. And the development of these interventions can take quite a lot of time and resources, and involves careful planning long before implementation can even begin. So when we try to map this out, it's not this neat linear diagram anymore. What we actually see is something that it looks something more like a web. So threads that are connecting interventions to stakeholders, and stakeholders to all of the different systems and the influences around them. It becomes quite messy, and it's very interconnected, and it really captures the reality of implementing point of care tests in a real world healthcare setting. I want to end my talk by saying that although clinical trials can really tell us exactly if certain therapeutics are effective, and they have, of course, a very important role when it comes to building scientific knowledge, they can only do so with a combination of other methods like qualitative research to discover not just like what works, or what not just to explain what works, but to really explain why things work or why things don't work or what happened, so we can think of strategies to implement them properly in practice. Social science, and in this case, qualitative research, can also contribute to increasing actually the effectiveness of interventions. So finally, to conclude, we need to do more than just identify a potentially effective intervention. What we need is very, very rich narratives regarding the environment of where an intervention is implemented, as implementation is not a linear process and does not happen in a vacuum. Thank you very much, and I'm open for discussions or questions.
Thank you, Melanie. That was absolutely fantastic. Really, really great. Have any people got questions? I'm sure you have. I particularly liked your closing analogy about sort of threads and connections and influences. I'm sure that's absolutely what is the case with this particular issue. Now, I see already some hands raised. Robert Hughes, I see, has his hand up.
Hi, can you hear me okay?
Hear you, yes. Can you hear Melanie all right? Can you hear Robert?
Yes.
Okay.
Excellent. Yeah, thank you very much, Melanie. That was fascinating. I was just wondering where you go next from here. What's the kind of next steps of using this information?
Thanks for your question. I think it's around, well, we already know what clinicians have to say, and we know what patients have to say. I think what we need to sort of understand better is this, how do tests complement other interventions, and how they can work in real life settings, and how we can better improve their implementation as a process. So to give an example, how does training clinicians, does that actually help them to understand the tools better? What are the other interventions that we need to support the implementation of these tests as well? So finding that sweet spot of which are the interventions that we've identified works best with what, in order for these tests to be implemented.
Okay, thanks very much.
Okay, we have another question from Colin Brown. Colin?
Yeah, hi, very nice, thanks. Did you get a sense of where people had to alter their patient pathways? One of the big challenges in the UK, for example, of any point of care test, but like CRP, is that it just, by the time you get the result, even with every more rapid test, you're already 20 minutes down the line and you're onto your third patient by then. And that's why even where in trial settings they've worked, they really don't work when they've been kind of, rolled out more rapidly. But they could do, clearly, if you identified a pathway whereby the patient was triaged in a different way, turned up early to reception, got a test. Was that mentioned as part of, any of the studies that you looked at about how best they did that?
Yeah, there were some studies that included triaging patients as you described, but we didn't look into how effective that was for them. It was just they explained it as a means of for a clinical trial, for instance, that was their way of doing things just to ease the burden off GPs. Yeah. But certainly it is a means of, but I mean, at the end of the day, when we look at some of the evidence, the problem is that some GP practices will need to change the way that they work if they're using quite clunky tests, especially if they want everyone to use them. Ideally, in some settings, you might have one practice with many GPs. You could have one GP that focuses on respiratory tract infections, and they would have access to the CRP machine, for instance. So there were different ways of working and different ways of actually finding a flow that best fits them. But at the end of the day, all of the practices need to find some way of making space for these tests, some form or another. Yeah.
Okay, Colin. Okay. Another question from Till Bachman. Till?
Hi, Melanie. Very, very good talk. Thank you so much. Can you hear me?
Yes.
Yes. Oh, very good. So yes, fantastic talk. So the adoption or implementation and adoption is one thing. Utilization, continued utilization of a diagnostic, and the use of the test results, the adherence to the test results is another. Did you find anything, or what's your view on clinicians following up on the test results, adhering to the test results?
Yeah, good question. Yeah, it's different because it's difficult because you find that in some studies, the clinicians, they would look at their test results, not just CRP, but to give an example, like the Strep A test, and they would look at their result and they would say, oh, I don't agree with this because it doesn't align with my clinical judgment. And instead they would turn to another test, and then they would use the results from that test to then help them build their clinical diagnosis. So in some cases, I think there is that risk of not following the test results. So for instance, you might, as a GP, you might find a patient and they tested positive for Strep A, but they might not want to prescribe them antibiotics because not every single Strep A infection needs to have antibiotics. But then how do you explain that to the patient? And that was one of the concerns that they had. So from the studies, it was important to really in the guidelines, it's important to have it clearly mentioned exactly what should clinicians do in order, if their clinical judgment doesn't match the test results. There should also be training in that as well. And a lot of the times there might not be that training. And so we need to fix those gaps. We need to ensure that clinicians have every tool at their disposal, and that they know exactly what to do if their results do not match, in order for them not to disengage with the tests in the long run as well. Because at the end of the day, these tests are really expensive, and we want to ensure that there is a sustained use over time rather than after a year that they stop using them. So having a clear set of interventions like training that fills in those gaps, those knowledge gaps, is important.
Thank you.
Can I take a question now from the chat? This is from Ahmad Zaman, and they say, have these findings during and post-consultation been in any way prioritized as the most relevant? If yes, how is this done? Or has prioritization not been necessary in this case?
may I ask what you mean by prioritization? Which aspect do you mean which part of the results are more important?
Yes, Melanie, exactly that one.
Um, it's really hard to say because no, answer shortly, no, there was no prioritization that actually took place. We didn't look into what are the most important aspects of the results. That being said, I don't think there is a single solution of the, like, I think every part of the results is important. We have to look at every stage of what happens before the consultation. So the workflow changes, that's important, because if you don't address those concerns, then you're not going to have the clinicians use them in practice as well. So I do think that at every stage of the results, there are important factors that need to be addressed. Of course, we cannot address every single complication or every single barrier, but the idea is not to reduce all of the barriers. The idea is to reduce them in areas that are most feasible, and yeah, in areas that are most feasible for us.
Great, thank you. And another question, Diane.
Thank you, Melanie. I'll preface my question if I turned up really late, so my apologies for that if this is already covered. Something that my name is Diana, I'm lead pharmacist for antimicrobial resistance at UKHSA. Something that's been coming up on when we think about point of care testing in primary care is around the risk of medicalizing point of care. By that, I mean patients turn up just to get a point of care test to check what they know probably doesn't need management, or vice versa, or things like this. Did you come across any of that at all? And we're also hearing that from countries where they have used quite a bit of point of care testing. They're now concerned about the increased use of point of care testing because of that. So just wondering if any of that came through in your research.
Yeah, definitely. I think this was a concern mainly from the clinicians, because they worry that there, as you say, there would be this medicalization of those self-limiting infections and this over-reliance on test results. Whereas clinicians, they really see themselves as you know, when they have a patient in front of them, it's not just the test result that counts. It's the clinical assessment, it's the symptoms that they present as well that counts and feeds into their results. So definitely from the clinician side, it was a concern. What we see from the patients, however, is a little bit more mixed. We saw that in some of the patient studies, they really said, "Oh, this isn't going to change my future health-seeking behavior. I'm not going to go and consult more in the future." But for others, yes, that was an issue. For instance, in the US, if you introduce, there was one study that piloted these tests in pharmacies, and what they found was that patients who would have usually waited to see how their symptoms would have progressed actually said later on that they would go much earlier now and go to their pharmacy to get tested. So definitely there is that balance that need to be struck between, okay, making tests available, but also equipping healthcare professionals with the necessary tools so that they can convey the right message of why the tests are used. They need to be trained to manage those patient expectations. I explained a little bit earlier on that one of the key components for a clinician was that communication, which is why they found training in communication skills as being more important than the tests, because they felt that communication was that key component in their profession. So it's a very roundabout way of saying, yes, it's a concern, but there are means to overcome these barriers, to overcome these sorts of issues, such as training and ensuring that the clinicians have the right tools to mitigate circumstances where a patient would come back and demand testing and only testing.
Thank you so much. That's really helpful. Thank you.
Thank you. Do we have any more questions? I wonder if I could ask one, Melanie. You used the term communication skills. quite a bit, and I wonder if in your work you had any, whether you're from your work able to identify what communication skills might be helpful, or what people meant when they were talking about communication in this context.
Yeah, so this was something that was created back during GRACE. So it was a trial that was done a while ago now, but it was a landmark study which really showed that the combination of CRP testing and communication skills was an effective means, was something that was notably important for clinicians and for patients in optimizing the way antibiotics are prescribed in primary care settings. And part of the communication training was around how do you manage, so clinicians were trained around how do you manage patients' expectations when they ask you, oh, I require antibiotics. So trying to help unpack that. And Samuel Kunin, who's one of the authors and researchers, a part of GRACE, has shared the link. So if you're interested more, I don't think I could give it justice, but
no, thank you.
They have the full thing over there. So yes.
Thank you. I shall look forward to reading. Any other questions or comments? I can't see any. So that just leaves me, on behalf of everybody, Melanie, to say thank you so very much for talking with us today. It was,
so I think there's a question. I see a hand up, I think. Sarah.
Where do you see? I must
have... It's me, Sue. Sorry. I just wanted to add on something at the end after we say thanks to Melanie.
Sorry. Okay, well, I'll continue to say thank you. It was absolutely fantastic and a real pleasure to hear about your work. Thank you from all of us.
Thank you very much.
Thank you, Mel. That was fantastic. I just wanted to share my screen because if you're already signed up to our People newsletter, you will have seen this. But for those of you who haven't, we just wanted to flag that we've got a call for funding out for EMCRs, so early and mid-career researchers. Unfortunately, this is only available to EMCRs who are at UK academic institutions for contracting reasons. So apologies, this isn't applicable to everyone on the call. But we have up to £144,000 available in pots of £36,000 for any EMCRs that want to lead a small grant that is relevant to transdisciplinary AMR and the scope of the People AMR network. Chika will put the links in the chat for anyone who's interested in applying for that. And we do have 2 workshops coming up next month in November in Oxford and Manchester, and that is a chance for EMCRs from all disciplines to come together and start talking about research questions for those grants. We have a facilitator on both days who can help small groups work together to come up to identify the problems in AMR, to identify the transdisciplinary research questions we need to address those problems, and to come together to think about what the design of those studies might be. So we really welcome any EMCRs that want to come and join us in Oxford and Manchester next month, and where you've got travel and accommodation money available for those who need it and who are coming from further afield. So please do sign up to our workshops if you're available on those dates, and we look forward to seeing you. So thank you everyone for joining us, and you will hear about our next webinar soon.
Oh, wait, sorry, I just wanted to say, address one of Ahmad's questions or comments here around policy making. Indeed, it is difficult with policymakers because they do kind of want to have that shortcut. Again, remember the flow chart that I showed. That's the way that they look at implementation. I think it's really important to stress to your policymakers the importance of, okay, yes, we can find interventions, or we can find ways to make it more tailored to the context. So for instance, just focusing on communication skills, which is quite a more Oh, is Ahmed still here though?
I am here, yeah, but that
Yes.
was not me. I don't know that that
Ah.
sound.
Yeah. So just to quickly say that train of thought, lost it. But yeah. No, it's definitely true. But it's important to make that argument that, okay, we can't address perhaps all of the issues, that all the barriers that have come up when it comes to implementing tests, and therefore we might need to look at a selection of interventions to support that. How can we make it more cost effective for the setting? But again, there is no way of really prioritizing, because across all of them, across all of the research, again, when we look at implementation science, the important thing is the value. Like, clinicians need to be convinced of the value, and in order for them to feel motivated to even start the steps of implementation, and then everything else can follow. So without that component, without trying to motivate them, or without even trying to stress or trying to find ways to convey that value of the tests, clinicians at the end, they're not going to adopt it. So you need to look at it at different angles. How are you going to engage with your stakeholders, with policymakers? What appeals to them? What appeals to the clinicians? What appeals to the patients? And that's why it's such a complex matter. Sorry, and that's all I wanted to say. But we're happy to take this offline as well. So yes.
Oh, thank you, Melanie, for responding to that. Again, thank you very, very much for all your answers to questions and to your talk. Fantastic. Thank you.
Thank you for having me.
Thank you, everybody, for joining.
Bye.
Thanks, Mel.